And it's really a pleasure to be here in this first of its kind virtual meeting that we've set up. And we have an esteemed group of panelists with us this afternoon to discuss about the malignant pleural effusion, the management, the diagnosis, and subsequent treatment. I mean, yes, we understand most of it is palliative, but even that is very important these days to give comfort to the patient. So I'm joined here as panelists with me by Dr. Ashish Kumar Agarwal, who's a chest physician, Ashirwad Chest Center in Ghaziabad. Dr. Pankaj Chhabra, who's a senior consultant, respiratory and sleep medicine at QRG Health City, Faridabad. Then we have Dr. Piyush with us. Dr. Piyush is HOD and consultant medical oncology sciences at Manipal Hospital, New Delhi. Dr. Gopal Sharma is the associate director again for medical oncology from Max Super Specialty Hospital, Patparganj. He also covers Noida and Vaishali. We have Dr. Sarvana Rajamanikam, who's the chief of thoracic oncology division, Thangam Cancer Center, Namakkal, Salem. And of course, my own dear friend and colleague at Max Hospital, Dr. Vivek Saxena. We've actually been together in the medical college as well. He's head of the department and senior consultant radiologist, and it's a pleasure to see him performing all those interventions that he does from time to time for our patients as well. Okay, so as the topic said, it has to be a case-based presentation. So I'll start with this case of a 70-year-old, sorry, it's a male, not a female, 70 years old male with dry cough, dyspepsia and fever for 3 months, sorry, dyspnea for 3 months. On an X-ray was found to be having a left pleural effusion. A diagnostic aspiration was done, which was exudative, lymphocytic in nature, with 60% lymphocytes and a lot of mesothelial cells, as it was reported. There were no malignant cells seen, and ADA was 32 and LDH was 450. So my first question is to Dr. Ashish Agarwal that, Dr. Agarwal, what do you make out of this kind of a report?
Hi, Dr. Vivek. I am Dr. Ashish Agarwal. First of all, my sincere thanks and congratulations to the organizing committee. If you see a new patient, if you see the pleural fluid cytology report, it was clearly exudate. It is lymphocytic with 60% of the cells and mesothelial cells. And as per the ERS and ATS guidelines, diagnostic pleural aspiration is the first approach to make the diagnosis of pleural effusion. And if you see, the diagnostic sensitivity of the pleural fluid cytology in malignant pleural effusion is near about up 60 to 90%, depending on the case severity and the extent of the tumor. Although cytology may be enough for the diagnosis of pleural tumor or the pleural metastasis, but it can also provide the useful information about the useful therapeutic information also. So in this patient, sometimes the mesothelial cells can be the false positive in patients of malignancy. So if you see regarding the pleural aspiration, definitely it is a first point to do in our patients to rule out the malignancy. As far as the biopsy is concerned, now the question is, should this patient be started on ATT?
As it happens in India, actually, anybody with a lymphocytic kind of a predominant effusion, irrespective of the ADL levels, LDH levels, started on ATT. So would you want to start this patient on ATT or would you want
No. Now first I want to confirm the diagnosis.
Yeah, right.
Either I will repeat the pleural fluid examination or I will go for the thoracoscopy and the biopsy.
Right. So you would definitely lead a biopsy better over a pleural fluid cytology. Is that right?
If you see, the second question is, how often do we get the pleural fluid cytology positive for malignant cells? Definitely it is up to the 90%. It is up to 90%. Some studies say it is up to 80%, but some studies say it is up to 90%. Suppose you are dealing with a patient of adenocarcinoma, then chances of pleural fluid cytology to be positive is high in comparison to the squamous cell carcinoma, because in squamous cell carcinoma the pleural fluid is usually because of the bronchial obstruction or the entrapped lung. What is more reliable, cytology or biopsy? In fact, first thing to do is the cytology. Biopsy, especially the thoracoscopic biopsy, is more reliable and confirmatory. But in patients of malignant pleural effusion, you can easily make the diagnosis by cytology in up to 90% of the cases.
But that is theoretical. You actually think practically also you get as often malignant cells positive report?
Yeah, very common. In our patients, if the history of malignancy is there, we are getting the pleural fluid positive for malignancy. Very often we are getting.
So, Dr. Gopal, there's a lot of advancement in the analysis of pleural fluid as well. Do you think there is any role of immunohistochemistry in this situation?
Yes, sir. Sir, in an era of precision medicine, ISC, basically immunohistochemistry, plays a critical role in the classification of tumors into subtypes and for assessing biomarkers for timely and accurate therapeutic decision making. Compared with other techniques, ISC has a number of advantages, including being widely available, technically less challenging and cost efficient, with rapid turnaround time and widely available in almost all tertiary care center. Thus, molecular specific ISC assays have huge potential as a practical screening tools for the detection of druggable genetic alteration and for the assessment of the biomarkers for the molecular targeted therapy. Because this is the era of targeted therapy and the prognosis and diagnosis. Basically, prognosis plays important part by this genetic alteration by the molecular therapy, molecular targeted therapy. So broadly on the ISC, the lung cancer is divided into three categories: adenocarcinoma, squamous, and neuroendocrine or small cell carcinoma. So in adenocarcinoma, the TTF1 positive and an FCA positive, while in squamous cell carcinoma, P40 and CK56 is positive, while in neuroendocrine carcinoma, chromogranin A, synaptophysin, and NCAM1 is positive.
Right. So really has a lot of role actually.
Yeah.
Dr. Piyush, Dr. Agarwal actually said that he would go in for a pleural biopsy, but what if this patient was to refuse for a pleural biopsy and would say, Doc Saab, I don't want to get any further intervention done? Would a liquid biopsy help in this situation?
So my apologies, I could not log in, just logged in when the case snippet was over. But as far as liquid biopsy now, its current application is concerned, where the tissue is, and especially in the scenarios probably being discussed where lung or minimal pleural malignant material is there, that is the positive material is scanned, where probably diagnosing the lung cancer, the IHC gets exhausted in classifying whether this is a lung cancer. Then to look into the molecular aspect of it, what Dr. Gopal was trying to allude to, that there are now certain subsets of druggable mutations. We can look towards liquid biopsy if the tissue is not really enough for further tissue-based assays. Liquid biopsy is something which has been established at least for EGFR mutation, and this at least we can know that for sure that what type of variants of EGFR at least are present. Apart from this, now there are issues as in what stage of malignancy are we dealing with? What is the burden of disease pattern? If the burden is high, if there are liver metastasis, the chances of getting positive liquid biopsy cells, that is the burden of the circulating tumor DNA, would be higher in such scenarios. If the tumor burden is small, then the circulating tumor DNA might not be robust. The fraction might not be robust enough to be captured by the assay. The other issue is that now we have a couple of assays available with us. One is Garden 360 and Foundation 1 Liquid. Apart from that, the assays need validity, and also they are expensive. So these are certain issues with liquid biopsy. But yes, of course, with minimal tissue, it definitely has a role. Yes.
So would you consider this as an adjunct or as a replacement?
It's an adjunct for now. It's not a replacement for tissue biopsy. We need to still work on validation, have markers on what would be the cutoff levels. So right now it's an adjunct for now.
Right. So coming on to Dr. Vivek, as both our speakers have said that a biopsy is very, very essential. So is this an era of, the blind pleural biopsy over now completely? Do we have to rely on you, or can we still try blind pleural biopsies in our patients?
Blind pleural biopsies are a little, the complication rate would be quite high. If we can do a biopsy only if we see the pleural thickening on ultrasound or CT scan. Otherwise, the thoracoscopic biopsy is something that should be recommended.
So what would you prefer in this case? Which modality would you prefer? Ultrasound?
So we generally go for a PET CT, and then if we see something on the PET, then an ultrasound guided biopsy is better because it's real time. Because the lung is always moving, so you need to be precise regarding, and the thickening is generally not more than 1 centimeter at max. So generally ultrasound guided is preferred. Yeah.
Right.
But yes, blind biopsy I don't think is
CT scan done, try and identify the hot spots in the FDG avid areas, and then do probably an ultrasound guided biopsy if there is pleural.
Absolutely. Yeah. If the pleural thickening is huge, then you can do a CT guided also. But if it's just nodules and some here and there small bits which are PET avid, then an ultrasound guided is preferred after the PET has localized whatever we need to do.
Right. So Dr. Sarvana, the next question is to you. Would you recommend doing VATS here?
Sometimes, the patients are the people who are making the decisions in this case. So fortunately, I'm in a place where people accept minimal invasive approach for getting a biopsy, and having a trained interventional radiologist is a difficulty. It's difficult to get good interventional radiologists in our place right now. So for us, it's cheaper because we have the equipment to do a VATS. So more than VATS, VATS is purely a surgical term, the domain of the surgeon. But, a thoracoscopy is something which is minimal and can be done even by pulmonologists. So image, that is vision guided biopsy, would be a must, especially in this current era of treatment of lung cancer, because you have so varied variety of tests that you have to perform on the tissue. Just having a positive diagnosis on cytology is not enough nowadays. You need ample tissue to do the additional tests required, to shift the patient to the medical oncologist later. So in our situation, in our place, and in our institution, we always prefer a thoracoscopic biopsy. Just the cytology alone, 90% I would say is a high number for getting it in our situation. You have a lot of fallacies with cytology. If the cellularity is, if you have a hemorrhagic effusion, then the chance of picking up malignancy is a little less. And then if you don't centrifuge or transport your specimens in the right way, and they don't reach the pathologist at the right time, you may lose malignant tissue. So there are a lot of fallacies. It's always better to go and see and get a biopsy. It will help us in the long run and for it.
Right. Dr. Pankaj, VATS can be slightly more invasive for the patient and going under GA. Do you think medical thoracoscopy will give you the answer? Is Dr. Pankaj there with us?
Dr. Ashish can answer that question because I don't see Dr. Pankaj here actually.
Okay. Yeah, sure. Actually, the medical thoracoscopy is definitely a good tool to make the diagnosis or to take the biopsy, especially when you are not confident with the diagnosis, especially if you are dealing with the case of malignant pleural mesothelioma and when the diagnosis is not clear, because the diagnostic accuracy with the thoracoscopic biopsy is more than 90% in comparison to the pleural fluid cytology, which is up to 90%, but with thoracoscopic biopsy, it is more than 90%. It is easy to perform, can be done by the pulmonologist. The patient can be discharged on the same day. So it has so many advantages in comparison to the VATS. But definitely, first thing to do is the pleural aspiration. Regarding the closed pleural biopsy, the added advantage is almost negligible in comparison to the thoracoscopy. So thoracoscopy is definitely a better alternative in comparison to all the procedures to make the diagnosis. Definitely.
I think the biggest advantage of thoracoscopy is that it gives you an on-site evaluation also. A visual inspection, which in itself gives you a diagnosis sometimes.
Yeah, added advantages of pleurodesis also. You can simultaneously do the pleurodesis also. You can visualize the pleura. Yes, definitely. It is better.
So this patient also underwent a CD-guided FNAC from the collapsed lung first, and they only got some few atypical lymphocytes. And then this was the medical thoracoscopy picture of this patient, where there are extensive deposits inside the pleural space. You can see these large masses, nodular masses. And this is like a spot diagnosis that it cannot be anything else other than a malignancy. And all you need to do is take biopsies from here and confirm that I have a malignancy and then start the treatment. In fact, we've also published an article of our own, which won us the best paper award in 2018, probably 2018 journal this was, and 2019 we had presented this. This is a clinical study to compare the diagnostic yield of pleural biopsy conducted under CT guidance versus medical thoracoscopy. And 120 patients, group A were the CT guided biopsies and group B were the medical thoracoscopy guided biopsies. Sorry. And of course, the medical thoracoscopic biopsies definitely scored way better than CT guided biopsies, but there was a subgroup of patients, as Dr. Vivek Saxena also said, that when there is pleural thickening, significant pleural thickening of more than 5 mm, then the difference between the two yields is not much. But when it is less than that, then there is definite advantage of doing a medical thoracoscopic guided biopsy. And as Dr. Ashish said, it also gives you an opportunity to evaluate the underlying lung. If the lung is expanding, then probably you could do the pleurodesis also in the same sitting. So Dr. Ashish, now comes that when would you want to consider doing a therapeutic thoracentesis? Supposing you don't have an access to medical thoracoscopy and there's a patient with massive pleural effusion coming to you, would you do that in the first go itself? Would you wait? What would your approach be?
Suppose if you are dealing with if you are suspecting the malignancy in the patient of massive pleural effusion, definitely first thing to do is a medical thoracentesis or the pleural aspiration to make the diagnosis. But if you are dealing with a patient of malignant pleural effusion, then I think therapeutic thoracentesis can give you the symptomatic relief, but this is not a permanent answer because this regimen has so many disadvantages that it can create the loculations. Recurrence of the pleural fluid is very high. In 1 to 3 days, usually the pleural fluid accumulation will be there. So in these type of patients, if you are dealing with the patient of malignant pleural effusion, it is always better to go for ICD, or you can do the pleurodesis, or go for the indwelling pleural catheter.
Right. So Dr. Vivek,
I think so.
Dr. Ashish has led us to this new modality of indwelling pleural catheters. So what has your experience been of putting in these ultrasound guided indwelling pleural catheters? I know you do a lot of them in the hospital.
So the indwelling pleural catheters are the best thing is they're accepted very well by the patients, and it is an outpatient procedure. And the amount of fluid drained can be titrated according to patient's needs. So it's a very good thing for people who have refractory long-term pleural effusions where the chemotherapy or whatever therapy is not going to work. And the only downside is a little costly, but otherwise it's an excellent modality. The patient doesn't have to come into the hospital very often, and it's an outpatient procedure. He has a good quality of life because he can take out fluid whenever he feels a little more breathless, and that way I think it's a good option. But if nothing's going to work, if the effusion is refractory and it's it's going to come again and again, so we have very good results in terms of that patient acceptance is very good.
And what has your experience been with the development of empyemas in these patients?
Generally, the risks of infection is also low. We have had one case in which there was some infection and we had to take it out. But otherwise, if the patient is tutored well of how to take care of the insertion site and it's used hygienically, then the risk of infection is quite low. Not only in our experience, but also in the general, the literature, which says that it's less than 5%.
Okay. So Dr. Pankaj is not there, but Dr. Ashish, would you like to take this question that when would you consider pleurodesis? Right on day one?
Definitely.
Or would you want to first evaluate that the lung is expanding or not expanding fully?
Yeah.
Or
actually, if you see the ERS guidelines in 2018, they extensively published that pleurodesis is the best option for the recurrent or the malignant pleural effusion. They clearly said. But when the lung is entrapped, or when the lung is not expanded, then indwelling pleural catheters are the best choice. So if you want to do the pleurodesis, you can do by the slurry or you can use the talc podraj. And the ERS, they clearly mentioned you can either use both the methods. Talc is the best agent to do the pleurodesis, and you can do it by slurry or you can do it by the podraj. Podraj can be done by the thoracoscope and the slurry can be injected by the ICD. Both works very well. If you see the success rate of the pleurodesis by the talc, it is near about 70 to 80%. And if you see the uh, overall patient comfort with the pleurodesis, it is very, very good. But you have to choose the patient before doing the pleurodesis. And definitely, your second question is, what is your agent of choice? My agent of choice is talc. I do the thoracoscopic talc podraj in my patients. I prefer talc podraj.
Some people feel that bleomycin, if you want a talc podraj, very good, but rather than instilling talc slurry, what if you were to use bleomycin? Bleomycin is also a cytotoxic agent. Do you think there's any advantage of using that over talc slurry?
No, sir. Talc is the best agent to use. In fact, the results and the comfort of the patient is very high with the talc. No added advantage with the bleomycin.
Right. So basically, you would only want to evaluate whether the lung is expanding or not, and based on that, you will take your decision whether to put in an indwelling catheter or whether to go in for pleurodesis. If the lung expands, patient's breathlessness improves, then you would go in for pleurodesis. If the underlying lung does not expand despite total thoracentesis, then you would want to leave an indwelling pleural catheter behind.
Yeah, sure.
So that would basically mean that there is an entrapped lung. So Dr. Saruna, I would like to ask you here that what if this effusion was septated or the lung was trapped? What would you recommend to the patient in this situation?
Okay, just to answer this question, actually, when you're doing medical thoracoscopy, like Dr. Ashish rightly said, then you have an opportunity to break the loculations or septations if you see them. If they are flimsy and they are easy to remove, it can be done while you're doing your medical thoracoscopy itself. And in our situation, we do a medical thoracoscopy when in the patient with the local anesthesia and mild sedation, they don't get GA. So the patient is spontaneously breathing during the procedure, and actually with every breath, you can see whether the lung is coming to oppose the the parietal pleural surface. So if you are able to do breaking of the loculations or septations in your medical thoracoscopy, and the the lung is reaching the chest wall, the parietal pleura, then it is safe to do a podraj in this situation. Whereas I personally get referred patients from a pulmonologist when they find that the lung is not expanding, or it's it is down and not expanding with the respiration, or if the patient is under general anesthesia, with every positive pressure the lung is not coming up, or if the septations are too thick. In those situations, and if the patient, in those cases where patient can tolerate general anesthesia, provided the patient has a long-term survival. So when we look at these patients in the clinic, we look at their performance status and we look at the probability of them surviving more than 3 months. If they would survive more than 3 months with the current medical therapy, the chemotherapy and other targeted agents, then and the patient would tolerate a general anesthesia, then it would be safe for those patients to undergo a VATS, decortication and separation of the lung, get the lung to expand, and then do a podraj at that situation.
So is there any role of cytoreductive surgery also?
Yeah, you have certain tumor subtypes which have a prolonged period of gestation. Even if they are malignant pleural effusion, these people tend to have a long survival even after being diagnosed with M1 disease. So there are select group of mesotheliomas are one. In that situation, then you have colorectal metastasis which have pleural nodules. In these two specific situations, there is a role of pleurectomy and cytoreductive surgery in this situation also. There is now added interest in adding, just before pleurodesis or podraj, there are current investigators who are instilling chemotherapeutic agents into the
that
thorax.
was my next question to Dr. Vajpayee, actually. Sorry, Dr. Kumar Sharma, that do you have any personal experience of using intrapleural agents or would you recommend patients?
Yeah, intrapleural chemotherapy is used for refractory malignant pleural effusion. So cisplatin is the most commonly widely agent, and that is relatively safe also. Other agents are like paclitaxel, cytarabine, mitomycin C, and bleomycin. But frankly, sir, in the era of this targeted therapy and immunotherapy, the role of intrapleural chemotherapy is very minimal. In fact, I have not used in my practice because there are number of lines of chemotherapy and immunotherapy are available, and the generally patient respond to treatment. So, but yes, definitely in rare cases, in selected cases, there is a role of intrapleural chemotherapeutic agent.
Dr. Vajpayee, one last question to you before we wrap up the evening. Would you like to discuss about the specific therapies for mesothelioma that are available these days?
A curative intent for mesothelioma is definitely a surgery. A good R0 resection done is definitely the most important therapy. Apart from that, neoadjuvant concept is important, especially in stage 3 mesothelioma, as well as there is a role of radiation therapy. Apart from that, the systemic therapy, chemotherapy, definitely pemetrexate-based therapy is there when we are talking about advanced mesothelioma. Apart from the chemotherapy, now we are actually looking into the possibility of after chemotherapy failures, looking into the possibility of MSI or Lynch related genes. If it is present, then we consider the use of immunotherapy. However, a non-operable mesothelioma has a median survival of nearly 1 to 1.5 years. So that is still a challenging situation. So this is what we have so far. Another recent update on the systemic therapy and the efficacy of chemotherapy being increased, another technology getting approved was alternating electric current fields. So this was there for glioblastoma multiforme, GBM, and now for mesothelioma, it is also acquiring a role and has been approved now for mesothelioma. Yeah.
Right. So before I sum it up, before I end this panel discussion, let me just sum it up for all of us here that we've really come a long way in the management of malignant pleural effusion over the last few years. Formerly, these patients would be bedridden, but nowadays with genotyping, phenotyping that is available to us, they can be treated on an ambulatory basis. Medical thoracoscopy and pleurodesis, oblique indwelling pleural catheters have significantly contributed to this change. But it's very important for us clinicians to choose our candidates appropriately and the right intervention, considering the cost, the clinical condition, and the expected survival and local expertise while taking this in mind. So thank you so much.